All right, and that button in the middle says we are live. So we are live indeed. Stacy, it's such a pleasure having you on our show today. And as a matter of fact, I forgot to tell you that you're actually a pioneer because this is the first time we're bringing Tea Talks to our Total Health business page. So we were using Sarah Loudon's, our founder's page, but then we thought it's time to grow it up and it's going to go on our business page because on our other business platforms as well on Facebook and link and YouTube. So you are the very first
Wonderful.
episode on our
Great.
business page, which is where it's going to be living from now on. So you're the guinea pig.
It's perfect to have a radiation oncologist on talking about technology. And also, I love going from the kids' table to the grown-up table. So that's
There
very
you go.
exciting.
Well, Stacey, why don't you just tell our audience who you are? Introduce yourself for us, please.
Sure. So I'm Dr. Stacy Wentworth. I'm an assistant professor of radiation oncology at Atrium Health Wake Forest Baptist. I am also the medical director of Cancer Survivorship. So I sort of wear two hats in that I direct our system cancer survivorship program and also am a practicing radiation oncologist. And I'm just excited to be here today.
Awesome. We're talking about survivorship in lung cancer. And one of the things that we talked about before we came on the air, we're talking about how little is known about lung cancer in the public's domain anyway. We hear a lot about breast cancer. And I just recently learned that as I shared that lung cancer actually kills more people. However, it's just not talked about enough. And so I wonder what's your take on that?
Yes, so living here at Wake Forest, which was really built by the R.J. Reynolds Tobacco Company, we are right here in tobacco country, so we're very familiar with lung cancer. The incidence of cancer peaked in 1991 and has been steadily declining since then. And most of that change or that decrease in cancer deaths has been driven by smoking cessation. Unfortunately, like you're saying, still 350 people die per day in the United States of lung cancer. But recently, the National Cancer Statistics showed that for the first time ever, we actually had a dramatic improvement in overall survival of lung cancer. And if you look over the past 30 years, the survival rate of lung cancer has doubled from 12% to 23%. And I think that there's a lot of opportunities to even improve on that more. We were talking before, low-dose screening CTs are now available and paid for through all ACA health plans, through Medicare. And we're only screening about 6% of the eligible population for lung cancer. So there's still a lot of work to be done that we did, 30 and 40 years ago for breast cancer. There's still a lot of work to be done in improving that survival rate for lung cancer through early detection, improved technology, and improved therapeutics. So I think it's a really great time to talk about lung cancer survivorship. And I think that lung cancer survivors are going to be a growing population as we move forward.
And that's just so encouraging to hear. We were talking about that before about this friend of mine that I met on LinkedIn who's a 7 or 8 year stage 4 lung cancer survivor. Yep. So I am really encouraged to hear that. And as we were saying, I think it's just a lack of information for somehow. I think lung cancer was just looked upon as that's for the smokers. And yes, maybe primarily that's who you're seeing. But, again, I quote this Dr. Porter, if you have lungs, you can have lung cancer. And so there's obviously more awareness needed. I'm going to ask some technical questions, even though we said we're going to get too technical. We're going to go not too techy, but as a radiation oncologist, you've had a unique vantage point in the journey of lung cancer patients. Could you shed light on the role of radiation therapy in treating lung cancer and its significance in improving survivorship outcomes?
Sure. So the best improvement, I think, technologically about lung cancer that we have is, first of all, the ability to properly stage lung cancer patients. And that really is the widespread availability of PET scans and MRI scans. So I'm old enough to remember the first MRI brain, and even the first CT scans of the brain that were really done to stage lung cancer patients. So appropriately staging patients has really allowed us to put them in better treatment groups. And then our computing power in radiation oncology has really improved over the past 10 to 15 years. So now, instead of just looking at the outside of a patient and kind of deciding based on outside landmarks how we can move forward with the radiation plan, we actually do a CAT scan, and it's called CT simulation or CT-based planning, which is absolutely standard in every cancer center in the United States, so that we can look at the inside of the patient. And in most centers, you actually take the PET scan that the patients had and you fuse that PET scan onto the CAT scan that you use for treatment planning. And that makes our radiation plans a lot more precise. We also use our computational power has allowed us to basically use the original AI, which is to tell the computer, hey, I want this curative dose of radiation to go to this lung cancer over here, but I don't want you to give this much dose to the heart and the lungs and the esophagus and all of the other critical organs that are inside the chest. And so before, a human would have to solve that problem. And so you could do maybe 7 or 8 tries in a day, but the computer in 15 minutes can go through millions of solutions to that problem and come out with a plan that really reduces the dose to the other critical structures. So those are some of the ways that we've been able to better target tumors by using PET scans, and then also through our computer power to provide better plans that spare critical normal structures. So it's a really exciting time to be a radiation oncologist.
It sounds like that. You know, as you were saying before, we've gone on the call. You were saying about just the advancement, you know, just improvements over the last 50 years. It's not our grandfather's lung cancer anymore. You know, it's so much more hopeful. And I think there's a little bit of denial, maybe. And I heard someone say this in terms of the screening, where I think people just don't want to know. I read an interesting post you did. I'm not going to go into it today, but you had a really great post about PET scans and how much is too much information. I really loved it. I'm not going to talk about that now, but I made a comment on your post. How much is too much? And if you just take a little piece of that post, right? And I think that's part of the blockage with people with early screening. They kind of like just don't want to know. But I think if the education could be, look, even if you are diagnosed with lung cancer, it's not time to pack your grip to go to the great beyond. It's time to like, okay, let's get it early, because earlier you have a better chance. And that's the message that, you know, I know you're trying to get out there. And we're hoping that, you know, platforms like T-Talks and our conferences can help get that message out. You know, we're going to be doing a lot of stuff, you know, with patients in the next few months and into next year. And I never thought of lung cancer as something we want to really highlight. But the more I'm hearing from doctors like yourself, I'm thinking we need to bring that forward as well. Now, one of my favorite topics is inequity and disparities, right, in care. And before we got on the show, you said, you know, there's a lot of inequity in survivorship, and you talked about your passion for the rural community. So tell us, what are you seeing in terms of the inequities in survivorship, you know, and what can we do about it collectively?
Well, we could talk for hours on that. So
I'm sure.
Yes. So we all know that, similar to other forms of social determinants of health, so things like access to food, access to transportation, access to insurance, access to good paying jobs, access to clean water, clean air, all of those things really determine our health. And those same determinants also determine whether patients have access to survivorship services. So there are some places that do survivorship very, very well. And if you are fortunate to be a patient in one of those areas or in one of those programs, you get excellent survivorship care and you're going to get all the tools that you absolutely need. If you don't, it's sort of catch if catch can. And I think a lot of times what I have seen is we try to solve survivorship in one area and we just hit it out of the park in this one area. And what I'm really more interested in, so Wake Forest just merged with Atrium Health and Advocate to become the 6th largest health system in the country. And I think what that scale allows us to do is to really create systems that allow survivorship exposure at appropriate times. Oftentimes, when I talk to people about survivorship, they really are focused on surveillance, which is very important. Is my cancer back or not? Secondly, they're really focused on dealing with the late side effects of their treatment, neuropathy or cardiomyopathy or skin changes or lymphedema or whatever that happens to be. What we don't really talk about is the psychosocial healing that needs to happen after a traumatic experience like cancer, and then also screening for other cancers. So 1 in 5 cancer survivors is going to develop a secondary cancer. We need to be monitoring and looking for that. And then also thinking of survivorship as a transition from illness to wellness. I was reading a wonderful post on Substack the other day, and it talked about survivorship as a chronic disease, and you sort of live as a cancer survivor.
Yeah.
But I also, and that really resonated with me. And how do you allow cancer survivors and empower cancer survivors in a very systematic way to live their best life as a cancer survivor and then back out into the community to somebody? I heard somebody describe it as my body is not my coffin.
Right.
And I thought survivorship really allows people to come out of that and say, okay, this is what I've been through. Maybe it's always going to be with me, but how can I open my lens a little bit and re-enter the world and control what I can control, and see the people I need to see and educate myself on what I can and move forward. I think that forward motion out of the illness of cancer and back into wellness is really important.
When you were talking about the survivorship, right, and the inequities, my question is, what is in the survivorship toolbox? In other words, so someone's, they're in remission of some sort, maybe, it's been dealt with, but we know that they have to be surveyed, and, there's a surveillance and so forth. What is in a survivorship toolbox? Because you're saying it's not getting to the rural areas as much. So, and we were talking about, if you're living near a big cancer center, yes, you're going to get access to more information and more care. But what's technically, intangibly or tangibly in a survivor's toolbox for lung cancer?
Sure. So for lung cancer, a lot of patients talk about fatigue. So we just are putting together a manuscript for 500 lung cancer survivors that have been followed for 3 years in our survivorship clinic. And their number one concern is fatigue. And that, I know you've had Sammy Mansfield on, and that is getting people hooked up with pulmonary rehab. Most hospitals across the country have cardiac rehab because of people having MIs and coronary artery disease. And pulmonary rehab is very closely related to cardiac rehab. And so sometimes it is that you can't bring back the lung function that, for example, has been damaged by COPD or damaged by radiation or is impaired because of lung cancer surgery. But gosh, how can we maximize what you do have? And so I talk to patients all the time about getting a referral. It's paid for by insurance to pulmonary rehab where you can be followed. And I think a lot of lung cancer patients, when I talk to them, are just afraid. Like, I don't know if it's okay for me to push myself when I get short of breath. I don't want to, not be able to breathe. So in a pulmonary rehab setting, I think it's sort of a monitored setting where patients are with a physical therapist, they're with a pulmonary rehab specialist, and they help them modify that. And then there's other, the Live Strong program, other cancer rehab programs that can help with that fatigue. A lot of patients have, I think that lung cancer is interesting in that there is some moral baggage that patients carry. Yeah. And I think that, you were a smoker. That doesn't matter. That isn't helpful. And I think having patients be able to talk to somebody either through an online support group or through pulmonary rehab or through a survivorship program is really helpful for patients to say, I mean, 20% of lung cancer patients aren't smokers. And
Right.
B, it doesn't really matter. Like, that's not important. What's important is you went through lung cancer treatment and now you're a survivor. How can we maximize your care? And I think getting access to those, I hate that it has to go on the patients to try to access those resources. And that's where I think building a system of survivorship that can go out to every clinic, no matter if it's a rural satellite clinic or in the main campus, is really where we need to go. So it's not up to the patients who've just been through this crazy experience
Right.
to then also connect for survivorship resources. But if you are in your community and you are a lung cancer survivor looking for pulmonary rehab programs, that's where I would start, hands down, and talking to your oncologist or your pulmonologist about that.
I have a follow-up to that, but before that, Sarah, I think you probably know Sarah. She's our founder and my partner in crime on this show. It's the other head in that little logo. She said, great point, Sharon. It's better to know when we can do something versus avoid and having little options. Having Dr. Wentworth as an advocate for this is so powerful. She also said, that was one of my follow-ups. Destigmatize smoking. It's so important. It's so people smoke. Okay, people drink. Educate that even if you were a never smoker, you can have lung cancer. And as a smoker, you might have a mutation that would have been a risk factor for cancer, even if you never smoked. It's that education piece. Now, I was part of the Atrium system. I was living in North Carolina when I got diagnosed. Oh, wow. Yes. And so I went through the Atrium system, which was phenomenal, right? I was on the Charlotte side. What role does integrative oncology, or does it play a role? Does integrative oncology play a role in the lung cancer survivors toolbox? I know that's where Atrium pointed me, and I was, referred to an amazing woman who is still in my life. And so do we have that same, resource for lung cancer survivors?
Yes, so that's why we're early on in the integration process. So we've been on a couple first dates, but we're not married yet. So
okay.
Yes, integrative oncology, and my colleague Susan Yaguda is the integrative oncology manager, and she's lovely. I really differentiate. Alternative therapies are, I'm not going to do regular medicine. I'm just going to do total alternative, non-evidence-based therapies. Integrative oncology, we were just having a conversation about this. There is plentiful randomized phase 3 gold standard data that the integrative therapies are really important in the care of cancer survivors. So there's great data on neuropathy and acupuncture, on mindfulness, on yoga, and on a couple of different supplements for improving fatigue. And so we really have our integrative oncology partners with us. It's almost impossible that every cancer patient or every cancer survivor is going to be able to see an integrative provider. But again, how can we provide them with information to say, here's a place to start, and if you want to go deeper, then we can get you a referral to a provider? Because I think so many survivors also don't want to be in the cancer center anymore. They're like, see you guys later. I want to be with my people. So how can we put those tools in their tool belt and say, here's some good community resources for you to access?
I think that's a great point of not wanting to be in a cancer center anymore, but we still want those services. And my integrative oncologist, she just started a company where it's all virtual. So you get the
wonderful.
And you get the therapy stuff and the referrals, and it's all virtual. And I actually saw her during COVID, so it was I never went to their office. It was all virtual, but it was such a big part of my own journey and my mental health that I honestly, if I was to wave a magic wand, right, and say what would I want to see in cancer survivorship, I would say for standard of care, everyone should have an integrative oncologist. They should also have an exercise physiologist, or someone in that exercise space, because those are new thoughts. I think, new way of thinking. When you grow up in your 50s, your experience with cancer is very, 50 years ago, what you saw in your community. So it's nothing positive. It's only negative. So even now with all of what's happening, if you're not in the cancer space, you really don't know. I didn't know a quarter, as much as I know now, just a year later in working with Total Health. And so there's so much more information needed. And I think if we could have the standard of care from the beginning, be like, okay, you're going to be, it's a journey, you're going to be challenged, but here are some resources, integrative exercise. Because like you said, Doc, people are thinking, if I exercise too much, am I going to have chest pains? I'm a lung cancer survivor. Just like with breast, they want you to lift weights. Can I lift weights with my breast? I had radiation. How long after do I need to lift weights? And all of this just requires education. So I love that you're passionate. You're my second lung cancer doctor. The two of you have this in common, passion, and you are both very clear on this point about destigmatizing smoking. And just the empathy, if I was a lung cancer patient and I smoked and I had you as my doctor, Dr. Shema, I'd be like, I wouldn't feel judged. I wouldn't feel judged. And I think it's very important that doctors are, they're more empathetic like you, so you don't feel as judged. So I just wanted to say that because it makes a difference.
I don't think judging people really gets you much in terms of working together. So it's where we are, and we need to, just moving forward, is the most important thing. Thank you.
Yes. No, I have a couple more. It's not, they're not too technical. Lung cancer treatments have evolved over the years. Like you said, it's not your grandfather's lung cancer anymore. Can you discuss some of the advancements in radiation therapy and technologies that have contributed to better patient experiences and outcomes?
Sure. So I will say I finished my residency in 2009. And at that point, stage 1 lung cancers were only about 30 to 40% curable. And that also is, if you're going to tell people to go get screened and we're going to find this cancer early, then gosh, you better have a good treatment for people. So back then, there was really no motivation for patients to find their cancer early if the cure rate was going to be essentially the same,
Right.
So there is a newer technology, well, it's, 10 years old now, over a decade old now, that's called SBRT. And for a lot of patients that were not surgical candidates, if they had to have radiation, we didn't cure very many of them. So a lot of them went to surgery and became basically pulmonary cripples because they had to have, or pulmonary disabled, because they had to have part of their lung removed, and they couldn't ever move again or walk again because they were so disabled from their lung surgery. This new technology of radiation condenses 6 weeks of radiation into 3 to 5 treatments and basically obliterates the tumor. And in several studies Yes, and it's very localized. It's called SBRT. There's many ways to deliver it. It's available in every community now, and all radiation oncologists are trained to deliver it. It's very standard for stage 1 lung cancer now, and it has about an 80 to 90% cure rate, which is the same as surgery. Correct. So we have multiple options for patients, even if they're older. I just got done treating an 85-year-old farmer who had a stage 1 lung cancer, and we treated him in 3 fractions. He did great. He had a little bit of shoulder soreness because you have to put your arms up, but he did wonderful, and he'll go on, and not die of lung cancer because we found this nodule early. So that SBRT approach, or radiosurgery approach, some people call it stereotactic body radiation therapy, or radiosurgery, lung radiosurgery, or all the different ways we describe it. That has been really exciting to be able to cure early stage lung cancer without having to do surgery.
That is incredible. Again, this is the kind of news data, I don't know, that needs to be shared, because you just hit on the nail. If people still believe in the old pattern, it doesn't matter if I'm stage 1 or stage 4. Once I have lung cancer, I'm dead. My body's in the coffin, right? Like you said.
Yes.
So why bother? I might as well continue to enjoy smoking. And I've honestly, I've heard that kind of talk, like I might as well continue to eat the way how I eat, or smoke the way I smoke, or whatever, live the way I live, because it doesn't matter. And so the incentive for early detection is just taken away. But we know with breast, it's it's emphasized and amplified. That message is everywhere. That the breast advocates do a great job with that. But I think lung cancer advocacy needs to do a better job with saying stage 1 is curable. Like with breast, we can knock it out. Doesn't mean you won't get something else back, like you said, but it's not the same. And so education is key. One thing that you said earlier, I just wanted to go back to before we end, because I've been hearing this from other doctors and folks in the scientific community about the management of cancer on a whole as a chronic disease, like you'd manage blood pressure or anything else that you have. You take this pill and you just keep going, type 2 diabetes or whatever. What do you think about that? What do you think about it as a doctor? Do you think that's something that's possible is coming to where, I'd love to hear your thoughts.
Yes, I think in some cancers that have specific mutations, the overall survival rate has gone from 1 year to 4 years. And I will tell you, Sharon, I've seen this happen in my career. I saw a patient who had cancer that had spread to his brain, and I sat down, this was probably about 5 years ago, and I sat down with him and his son, and I said, you're probably going to live 6 months or less. We're going to try to do this brain radiation to keep you comfortable, but, wrap up things and make sure that you have your affairs in order. And I mean, we had a longer conversation than that, but that was basically what I told him. And I just saw him in follow-up 3 years later. And he always tells me, you know what, doc, you were wrong. And I think it's such a wonderful thing. I love being wrong.
Yes.
So, and it is a testament to the developments that are happening with liquid biopsies, with targeted mutations. So I do think that there is hope on the horizon. And I heard a medical oncologist describe it sometimes with patients as just going vine to vine. So if we can keep you swinging on this vine long enough for somebody else to develop something, then we can get you to the next vine. And so I think there are many cancers that are chronic disease right now. And I see lung cancer entering into that arena, which is really exciting.
Dr. Stacy, it was so pleasure. I could talk to you for another hour because it was so interesting. And what you're saying is so refreshing, so hopeful. It's so encouraging. It was just wonderful, really learning from you. I had like 3 more questions, but okay, maybe I'll do one more. Oh, I'll do one more. So I'll do one more about survivorship, and then I'm going to have you close on a high note, right?
Sure.
Survivorship encompasses a range of physical and emotional challenges, right? We know that. The emotional, yes, for sure. From your perspective, how do you and your medical team support patients during and after radiation therapy to enhance their quality of life during survivorship? We talked about the survivorship toolkit, right? We talked about sending them to, maybe some exercise and stuff, but is there anything else that you'd like to share because of the emotional, factors, especially the fear of the recurrence and what you've lost, not so much what you have? How do you and your medical team address that?
Right. So currently for all of our stage 1 patients who are treated either with surgery or radiation, they're referred to survivorship clinic at 6 months. And their first appointment is a 1-hour survivorship orientation visit. And I called it a survivorship orientation visit because what we realized that a lot of patients didn't hear what was happening to them at the beginning. And if you have survivors that are on the call, you probably remember, as soon as somebody said you have cancer, it's just Charlie Brown's teacher after that.
Right. That's right.
So, yeah. So we start in that 1-hour orientation visit, which is staffed by nurse practitioners and physician assistants, which are wonderful partners, which we didn't get into, but they're wonderful partners in survivorship. And they sit down and go soup to nuts with the patient. What was your diagnosis? What type of cancer did you have? What was your treatment? And then we send patients before their visit a patient-reported outcome survey that really drives the rest of that visit. And we focus on whatever the patient reports to us. What are the 3 or 4 things that they really want to talk about in the hour-long visit? And so that really is a visit that's directed with pairing the patient-reported outcomes with the resources that we know that are in their communities. And we really,
Mm.
at Wake Forest, we see a lot of patients from the mountains. We see a lot of patients from Southern Virginia and, in the Triad areas. So we are familiar and try to continue to connect with resources in all of those different communities. And I
Yeah.
think that 1 hour visit is just so important for patients to just sort of take a breath, sort of put together. We actually give them a care plan, but it's not a long document and it's mostly resources so that they can kind of put that on the shelf. And when that fear of recurrence comes back, they can bring that out and say, okay, what resources are available? And also
Right.
remind themselves of the things that they did to control that fear and the things that they did to control that recurrence. A lot of cancer is out of your control, but really as patients, I think whatever your treatment is, I think patients really do as much as they possibly can to control that risk. And after
Yeah.
that, it's just not up to you. And so
Yeah.
we sort of walk through that with patients and say, look at all the things that you did. Don't forget about that as soon as you walk through as soon as you walk back out of the cancer center. You did all these things. So I think
Mhm.
that orientation visit is really important, and it really addresses those patients early on so that they can go on to survivorship. So I could talk forever, Sharon. I'm sorry to take so much of your time.
Well, that's such a wonderful service. Look, I'm a little bit biased toward Atrium. Okay, as I explained to you, that's where I had my journey, and it was exceptional. So it's just good to see and hear from you in a different type of cancer that patients, and if someone's watching and you are someone or you love, um, is afraid to get screened or has been screened, and at some stage, there is still hope out there. We didn't talk about stage 2, 3, and 4. But I mentioned earlier, I know a stage 4, 8-year survivor. And so there's a lot of hope. It's not your grandfather's lung cancer. Last question, and it's the last statement from you, Dr. Stacy. T-Talks, right, was based on the whole notion of the T cells being the cells that knock cancer out. So we always ask our guests to give us something that's going to stimulate our T cells and stimulate the persons watching in the replay their T cells regarding this topic. What would be your last word to that cancer survivor or newly diagnosed or someone whose loved ones going through that?
Right. So my plug is always to call your representative and call your senator and to ask them to vote for the Cancer Survivorship Funding Act. It's a bipartisan, bicameral bill sponsored by members of both parties in the House and the Senate. We don't have enough research on what to do with cancer survivors. We need research and we need funding to provide survivorship care. And it's one of the rare things in Washington that has bipartisan support, and our lung cancer survivors are a growing population, and we need more data on how to best care for them. So if you're a cancer survivor or you're a cancer advocate, that bill has been introduced in the House and the Senate. And I call every Friday on my way home from work. I call both of my senators and my representative and tell them, they're like, oh, hello, Dr. Wentworth. Yep, you know what I'm saying. So I think that we really do need more research, more evidence-based practices on how to care for survivors.
That is very cool to know. Okay, I will definitely join that phone call log as well, because yes, we need, if that's where we need funding to extend people's quality of life, which is something that we know there's unfortunately a lot of cancer diagnosis, right? So anything that we can do to enhance the quality of those who are still here. Doctor, thank you so much for your time, and thank you all for watching. And for those watching in the replay, you can still post your questions. The doc will circle back and answer when she gets a moment. So thank you so much for watching. And Doc, thank you very much once again. And for the rest of you who follow T-Talk, we'll be back here tomorrow. We're talking about clinical trials. I think I'm not quite sure. I don't remember. But for now, we'll just say goodbye and just thanks again.